Welcome back. So this is our respiratory video lecture, and this is going to cover lower respiratory disorders pathophysiology. So by the end of this lecture, you should be able to explain the pathophys of all these different disorders of the lower respiratory tract, talk about the etiology, signs, symptoms of the disorders, be able to identify the tests that we use to diagnose lower respiratory disorders, therapeutic measures that we use to treat them, data collection, both subjective and objective, when we're treating patients with lower respiratory disorders, nursing diagnoses and interventions, and then, be able to explain when we do intervene, how do we know that that intervention was effective? Did it work sufficiently? And the first thing we're going to talk about, this one will be brief, is bronchiectasis. So bronchiectasis is due to typically chronic infections of the lungs. And what happens is it's almost kind of like scar tissue that builds up inside the lung from these chronic repetitive infections like bronchitis. And what will happen is that the bronchioles will start to dilate. If you look at slide 4, you'll see a diagram of the bronchiole when it's normal, and then that dilated bronchiole. And this disorder is usually secondary to something else. So you'll see this often in people with COPD and asthma and tuberculosis because it's a chronic disorder that's causing damage to the bronchioles in the lung. We talked about the pathophysiology, the etiology, signs and symptoms. Almost all of these are going to have similarities in signs and symptoms like dyspnea, shortness of breath, cough, sputum. When we're talking about sputum, phlegm, large amounts of sputum, anorexia, loss of appetite, and you'll see clubbing of fingers. And there's a picture down the road in this lecture that shows you what it looks like. People that have chronic lower respiratory disorders, because they are chronically hypoxic, will have these symptoms and signs. And one of them is a telltale clubbing of the fingertips. So when you see that, that should trigger your brain to say, oh, that is a chronic lung disorder that this person has. And then, of course, you will hear wheezing. And wheezing is that lovely musical sound that usually with expiration, by the way. So when the person's breathing in, it's normal. When they're breathing out, you hear this almost the musical sound. And that is the air that's trying to get through these constricted airways. How do we diagnose it? Well, chest x-ray, CT scan, and MR are two of the better ways to diagnose it because they show soft tissue and things that x-rays don't. And then, of course, what is the underlying cause? And we need to treat that. And then therapeutic interventions. Well, if it's because of an infectious process, treat the infection. If it's bacterial, antibiotics. We can use mucolytics and expectorants to help them get that viscous phlegm out. Bronchodilators, like albuterol. Chest physiotherapy, which I talked about in the very first lecture, cupped hands, on the back that help to mobilize the secretions in the lungs and help the patient expectorate. Oxygen. And sometimes if it's really bad, they may need a surgical resection. So that's it for bronchiectasis. Next, we'll talk about pneumonia. Pneumonia is an infectious process. Okay, so don't confuse signs and symptoms of pneumonia with signs and symptoms of congestive heart failure, which we will get to when we get into cardiac. Pneumonia is an infection. It can be viral or bacterial. And what happens is the patient will get a lot of this purulent exudate. In other words, thick phlegm. And it will actually infiltrate in the alveoli inside the lungs. And when the alveoli are filled with all this phlegm, mucus, they can't exchange oxygen and CO2. And so what happens is the patient becomes very severely dyspneic or short of breath. Again, etiology of this, bacterial, usually Streptococcus pneumoniae, which is the name of a particular bacteria that's notorious for causing pneumonia. But it can be viral. It can be a fungus, a mungus. Or there's something called aspiration pneumonia. And aspiration pneumonia is when a patient inadvertently has something foreign, it could be food, drink, or even a foreign object, enter the airway and get into the lung. and that foreign body sits there and causes this infectious process. So there are other reasons like ventilator-associated pneumonia and chemical pneumonias. Don't worry about those. Really, the ones to focus on: bacterial, viral, fungal, and that's going to make sense when we get to HIV, and then aspiration pneumonia. And who's at risk? So I say this all the time: the very old, the very young, right? Because they're the most fragile. So very young, they don't have mature immune responses, so they, are more a higher risk for, having complications. And then the elderly, you should know this. Make sure you commit this to memory. The most serious complication of influenza is pneumonia. And those most likely to develop that complication from influenza are the elderly, okay? And people that are hospitalized are at risk because hospitals are filthy, okay? Filthy places. If the patient has been intubated, in other words, an endotracheal tube is down their throat because they need a mechanical ventilator, assistance with breathing, they are at risk. And anyone that's immunocompromised, so their immune system is not working the way that it should be working, they are at risk as well, okay? And so what do? The best thing to do with any disease, I don't care if it's respiratory or otherwise, prevention. So if it's elderly, they should get their pneumococcal vaccine, and that's after the age of 60. They should get an annual flu vaccine. Practice coughing and deep breathing, hand washing. If they are ventilated, we must make sure that their airway's free from secretions, okay? To make sure, because when secretions sit, then they can become infectious. Signs and symptoms of pneumonia, again, it's an infection. So patient can have chest pain just because it hurts to breathe. Fever, chills, cough, dyspnea. They can have blood-tinged sputum, which is hemoptysis. It can be thick yellow or green colored sputum. Anyone who's ever seen that knows what I'm talking about. Wheezing, and then especially with the elderly, just general lethargy and malaise. Lethargy is they have no energy, and malaise is they just don't feel well, okay? So those are all signs and symptoms of pneumonia, okay? With the other signs and symptoms in the elderly that you need to commit to memory that are important, they don't always have a fever, okay? So the elderly tend to have a body temperature at rest that's a little lower than the rest of ours. 98.6 is typical normal body temperature. Elderly people tend to run a little lower than that. So if they're running normally at a baseline of, say, 97.6, if their temperature is now 98.8, it doesn't really seem like it's a fever. But the big thing to keep in mind with the elderly is a new onset of confusion. So when a patient presents with a new onset of confusion, they weren't confused before, and now they are, it is usually secondary to hypoxia. So the brain's not getting enough oxygen, and that makes them not be able to think clearly. So therefore, that's causing the confusion. And what do? Well, we have to treat the pneumonia and resolve that hypoxia, get them oxygenated, okay? Complications. So pneumonia can have its own set of complications. And pleurisy, which we talked a little bit about, but just to give you an overview, pleurisy, inflammation or infection of the pleural viscera. It's that space that's around the lung. Pleural effusion. In other words, they can have empyema, which is exudate, mucus, phlegm, thick, purulent exudate in the pleural space. They can suffer from atelectasis, and atelectasis is an actual collapse of the alveoli inside the lungs. And then, of course, spread the infection. So if we're talking about a facility, a nursing home or a rehab, one person gets it, it's going to be very hard to contain and very, very easy to spread very quickly. Well, how do we diagnose it? Chest x-rays for pneumonia are usually pretty good diagnostic tools because they'll show us areas of consolidation. That's where all that phlegm is kind of gathered together. And then, of course, we can do sputum cultures and blood cultures, trying to identify the bacteria that's the culprit. And therapeutic interventions, well, if it's bacterial, give them antibiotics. If it's viral, antivirals. And then when we talk about treating symptoms, So with therapeutic interventions, don't confuse treating symptoms and treating the cause. So to treat the cause of the pneumonia, again, antibiotics or antivirals. But while we're treating the cause to palliate the patient, make them more comfortable, we treat the symptoms. So we can use short-acting bronchodilators like albuterol. We can use expectorants like guaifenesin, Mucinex. Of course, oxygen. And you want to push fluids as long as it's not contraindicated. In other words, as long as there's not a reason they can't have increased fluid intake. The more fluids that they can take in safely, the more the secretions get liquefied, thinned out, and it's easier for them to expectorate. That's it for pneumonia. And so now we're going to talk about good old TB. Remember, airborne diseases. I want my MTV. That's all you have to remember. Measles, tuberculosis, varicella. Those are the 3 diseases that are airborne. So TB, what is it? Well, the pathophysiology of tuberculosis, it's a bacterial infection. So the acid-fast bacillus, which is that particular type of bacteria, get in and implant into the bronchioles or the alveoli inside the lungs. If you're generally very healthy, young, adult, you may be exposed, but you may not become actively infected with it. So you'll see, for example, in very, very crowded conditions in some foreign countries. I'll use India as an example. The capital of India is Mumbai. It's very crowded, dense population, high rates of TB. Not everyone is sick. So, but if you tested everyone using a PPD, you'd get a lot of positives, but they're not actively ill. So they've been exposed, but they don't actively have the disease, okay? And if they've been exposed and then later down the line, they have a problem with their immune response, the disease can come to life or activate. So that's important to know. So who's at risk? Again, it's the same old song and dance, the elderly, right? People living in crowded conditions, immigrants, especially from third world countries, people with HIV, which is the human immunodeficiency virus. They are especially susceptible to tuberculosis because they have no immune response to speak of. What are the symptoms? Well, they're going to have this chronic cough, blood-tinged sputum, hemoptysis, night sweats, anorexia, loss of weight, right? Because they lose their appetite, so they lose weight, low-grade fever, dyspnea, and then later in the disease process, it becomes painful. So if they're not treated for it, they will experience chest pain. How do we test it? Well, PPD, and you need to know what that is. PPD is the Purified Protein Derivative skin test. So we give an intradermal injection, and it's 0.1 milliliters. In other words, 1/10 of a milliliter of this PPD in an intradermal injection, and we create a little bleb, that's what we call it, on the inner aspect of the forearm. And what we do is we do it and we wait 48 to 72 hours and then go back and feel the area. What we're feeling for is something called an induration. An induration is a lump or swelling at the area. And we should know that an induration of 10 millimeters or more is indicative of a positive test. And if somebody's immunocompromised, so for example, someone has HIV, or someone is being treated for cancer with chemotherapy or radiation therapy, both of those things suppress the immune system, then we're looking for 5 millimeters, okay? Redness is not a positive. Let me say that again. Redness at the site is not a positive. There must be a lump or swelling or induration. All 3 of those things mean the same thing, okay? And once positive, they never get a PPD again. So you would never do a follow-up PPD. Once positive, never again chest x-rays the rest of their lives. So make sure you know that. Don't worry about quantiferon, and we're not going to talk about that. Therapeutic interventions, it's always more than one drug, usually 2 to 3 drugs. The 2 common ones that you have to know, isoniazid and rifampin, okay? They're the 2 that you have got to know about. Pyrazinamide is one that you may want to just put in the back of your mind, but definitely for ATI and for the boards, isoniazid and rifampin. And rifampin starts with an R, So remember, rifampin is the one that turns all body fluids a reddish orange color. So the person's sweat, tears, saliva, and urine is going to be a reddish brown color, reddish orange color. Make sure they're aware of that. Okay? You don't want to scare them. For precautions, airborne transmission-based precautions require the person must be in a private room, isolation, negative pressure room. They have special filters in those rooms. The room pulls the air out into this filter so that it doesn't get mixed in with the rest of the air in the facility. The nurse, you have to wear an N95 mask, which is a fitted particulate respirator. It's not a one-size-fits-all. And if the patient should need to leave the room and be transported, say, to X-ray or whatever, and only if it's absolutely necessary, then you must put a surgical mask on the patient. So the N95 for you, surgical mask for the patient. Make sure that you remember that, okay? And then the next slides talk about some nursing diagnoses and really give you interventions. So slides 22, 23, 24, 25, 26, and 27 give you nursing diagnoses interventions. So now we're going to talk about restrictive disorders. Okay, so restrictive disorders mean basically that something's restricting the lungs from expanding. And this is where we talk about pleurisy, and we'll talk about pleural effusion and those kinds of things. So we'll start with pleurisy. Pleurisy is an inflammation of the pleural space, the space around the lung. And the inflammation is usually secondary to another disease. And usually TB is the big one, but it can also be secondary to pneumonia, it can be secondary to cancer. And when you listen with your stethoscope, what you hear is a pleural friction rub. So when they inspire and expire, it's like something's grating. Okay? Other signs and symptoms. It hurts when they breathe in. Sharp pain with inspiration. Their breathing will be shallow because they know that it hurts to take a deep breath, so they won't. And that's a problem. Fever, elevated white blood cell count, and then that friction rub that I talked about. So we're going to do a CBC, check out their white blood cell count. You should know what a white blood cell count is normally, 5 to 10,000. Chest x-ray, those are the two that you definitely need to know. And what do we do to take care of them? Well, manage the pain, and then whatever the disease is that's causing the pleurisy, we must treat that. And when we do that, we treat the pleurisy. The next thing we'll talk about is a pleural effusion. A pleural effusion, and you can see on slide 33 that diagram, shows you a normal lung that's on the patient's right side. And then the patient's left lung, you can see down at the bottom this collection of fluid that's built up and kind of stuck in that pleural space. And what happens is that fluid in the pleural space puts pressure on the lung, and the lung can collapse. So, there are many reasons for pleural effusions. I'm not going to get into the transudative versus exudative, but the bottom line is that you should at least be familiar with what it is and understand that, that fluid stuck in the pleural space. You'll hear a friction rub, signs and symptoms, shortness of breath, dyspnea, pain with inspiration, cough, tachypnea, which is a rapid respiratory rate greater than 20, and then diminished lung sounds. And for that patient, we're going to do a chest x-ray and possibly thoracentesis or a chest tube placement, okay? If you look at slide 37, again, we have to treat the cause, give them pain management. There's a picture of a gentleman with a chest tube, and it's showing you the insertion site of the chest tube. So that is one intervention, and a thoracentesis, which you can see on slide 38, is instead of just the tube staying in, thoracentesis, we use a needle and syringe to basically go in through the ribs and aspirate or pull out the fluid that's in there. Okay? All right, moving along. Atelectasis. Atelectasis is a collapse inside the lung of the alveoli. And, hypoventilation is usually the most common cause. And hypoventilation can occur for lots of other reasons besides just an anxiety attack. But one of the big things that you can see, and when you see it for the first time, you will know. A sign of atelectasis is a tracheal deviation. So the trachea that should be midline will actually turn towards the affected side. So that is a telltale sign. You can look at someone, and if their trachea is leaning to the side, they've got atelectasis, okay? What do we do for this patient? Well, the best thing, again, is prevention. So make sure, your post-op patient should be coughing and deep breathing, incentive spirometer every hour, 10 times an hour. If they're not mobile, we need to be turning them frequently, minimally every 2 hours, ideally more frequently than that. And if they are able to, as soon as they are able to, get them up. Early ambulation, okay? That can prevent so many complications of surgery. I can't even list them all right now. Next, we'll talk about a pneumothorax. So a pneumothorax is a collapsed lung because of air in the pleural space. So it can be a partial collapse of the lung or a complete collapse of the lung. And when we differentiate them, there are 3 types: spontaneous, traumatic, and tension. Although I like to tell you that tension pneumothorax is usually a traumatic pneumothorax that's really severe. So a spontaneous pneumothorax, which is in the first diagram, A, is usually a young man, usually males, young age, say late teens, early 20s, and they have this thin, tall, lanky build. And sometimes for no apparent reason, there's no trauma, nothing happens, the lung whoop, just collapses. And it has more to do with their anatomy than anything else. Traumatic pneumothorax, that's pretty easy to understand. If there's any type of a puncture into that thoracic cavity, it could be a stabbing, it could be a bullet wound, a shooting, then that's going to cause air to get in, right, to that pleural area and put pressure on the lung and make it collapse. And when it's very severe, now you're looking at a tension pneumothorax, because the difference here is that they have what's called a mediastinal shift. So everything brings their trachea right along with it, will actually shift over to the unaffected side. Right? Signs and symptoms, they are going to have shallow and very rapid respiratory rate. You're going to see asymmetrical expansion of their chest. So if I have a pneumothorax on the right side, my right lung, you are going to see my left lung is still expanding, right, and contracting, but there's not movement on the right. And also, if you auscultate with your stethoscope, you will not hear breath sounds at the affected areas. So we're always going to do, of course, a H&P, history and physical, ultrasound, chest x-ray, ABGs, check their SpO2. But, just remember, with a tension pneumothorax, and I'm at slide 44, this one is traumatic, but it's severe. So this one, if we don't act immediately, chest decompression, in other words, get the pressure in there back to where it needs to be, the patient could die. Right? And so the telltale sign is that tracheal deviation, the mediastinal deviation, and you will see them with severe bradycardia. Heart rate will drop significantly. They will look cyanotic. So you'll see a blue tinge around the lips, fingertips, etc. That is a telltale sign. And that's it for that. Now we will move to obstructive disorders. So with obstructive disorders, there's some type of obstruction, right? That's usually making it's not so bad for the air going in, but they can't get it out, okay? And this is where we get into COPD, chronic obstructive pulmonary disease. So chronic obstructive pulmonary disease is an umbrella term, and it encompasses 3 different diseases, which are chronic bronchitis, chronic asthma, and emphysema. Okay, those are the 3 diseases that all are a form of COPD. Okay, and so the first one that we will talk about, actually, even before we do that, let's take a look at slide 48 that shows you a normal lung versus a lung that has COPD. And what happens is the walls of the lung start to get thinned and the air gets in, but then it's got a real hard time getting back out. And so the exchange of air, in other words, when we exhale, we are releasing carbon dioxide. with these patients, they are retaining carbon dioxide. That is the biggest problem with COPD, is the retention of carbon dioxide, which, by the way, is called hypercapnia. And when patients with COPD pass away, hypercapnia causes respiratory acidosis, because remember, carbon dioxide is acidic, okay? The pathophysiology will start off with bronchitis. Chronic bronchitis versus acute. Acute bronchitis and chronic bronchitis, they're both infections, okay? But when it's acute, it's a sudden onset, it lasts a short time, it's treated, and it leaves. Chronic bronchitis is just repetitive. It keeps coming back over and over and over. So if they're ill with bronchitis for 3 months out of a year, for 2 years or more, it's chronic. It's not acute anymore. In other words, it just keeps coming back. And what happens is with these recurrent infections, the mucus glands in the bronchi get hypertrophied. They get enlarged and they don't function right. The cilia, which is they're kind of like little hairs inside here that are supposed to ward off pathogens like dust and bacteria and things from getting in. They can't work right. They have ineffective airway clearance, and boom, COPD. Bronchitis. Emphysema is destruction of the walls of the alveoli. So the alveoli are kind of like elastic. They bend, right? They give and wax and wane because air comes in and air goes out. Air comes in and air goes out. That's where the exchange takes place. And they get damaged. And so air gets trapped inside, which is CO2, and they can't get it out. And there's a nice little diagram that shows you what air trapping looks like, particularly with emphysema. So that carbon dioxide is stuck in there and they just can't get it out. And I mean, I hate to say this, but number one reason, etiology, cigarettes, right? So not for me, but other people, right? So smoking, passive smoke exposure, in other words, secondhand smoke. And then of course, pollutants. So if somebody, say, works in a coal mine and they're breathing in coal dust, or they work in some kind of a factory setting where there are different kinds of pollutants in the air, well, that's a risk factor too. It can cause it. And familial predisposition. In other words, it runs in families, okay? There is a particular type that's a deficiency of this alpha-1 antitrypsin, but you don't need to know that. So I'm not even going to highlight that one. No one will ask you about it, okay? Signs and symptoms, cough, sputum production, usually a lot. Can be yellow, can be green, can be brown. Dyspnea. Prolonged expiration. So shallow. Breathe in. Right? They'll have this barrel chest that it has expanded so many times that it kind of stays that way. It looks like a barrel. And activity intolerance. They get to a point where they're unable to even eat. Okay? Because to eat, you can't breathe and swallow at the same time. And so people with COPD are typically very thin and sometimes and very often malnourished. So when we're doing dietary teaching for people with COPD, one of the most important things is small frequent meals, which, by the way, is the answer to life, just so you know. It's the healthiest way to eat. And for these guys, the more bang for your buck. In other words, you want high calorie, high protein, small quantities over the course of the day. And also, no fluids with meals. Anybody that's got a kid knows that if your kid has a drink and a meal, if they start drinking their drink, they'll drink all of it and then they won't eat. So it's the same thing with people with COPD. Fluid will fill you up very quickly and then they won't eat. And so that just contributes to their malnourished state. Signs and symptoms, wheezing sometimes crackles, right? With chronic bronchitis, chronic cough, dyspnea, thick, tenacious sputum. Tenacious and viscous are words that we use to describe the sputum. It's thick. It's so thick, it's sticky. And it will stick and they can't get it out, right? And because of this, they have an increased susceptibility to infection. They will catch any infection that comes down the pike, okay? With emphysema, they're going to have diminished breath sounds, dyspnea, and their activity intolerance is progressive. So in other words, it's not going to get better. It's only going to get worse. On slide 56, I give you an example of a normal versus a barrel chest so you can kind of see what it looks like. And there is a great picture of what clubbed fingers look like. Okay? You see that hand and your brain goes, oh, COPD. Okay? And COPD can cause other complications. Cor pulmonalis, right-sided heart failure, weight loss, malnourishment. It can contribute to a pneumothorax, and it leads to respiratory failure and death. Okay? So that's important to know. How do we diagnose it? Well, chest x-ray, CT scan of the chest, ABGs, arterial blood gases, CBC, looking for elevated white blood cell count. Again, don't worry about the alpha-1 level. I'm even going to remove that from this slide. But spirometry tests to measure what the amount of air inspired and expired in their lungs is, and a sputum analysis to see if there's an infectious pathogen in there, like a virus or a bacteria. And then therapeutic measures, definitely take a look at all of this. You know, prevention, prevention, prevention. Don't smoke is one of the most important things that we can tell patients. And if they do smoke, they should stop if it's at all possible, right? Oxygen, of course. And here's a real big caveat with oxygen therapy, all right? People with COPD, again, their biggest issue is the retention of CO2. And so we will typically give them oxygen somewhere around 2 liters, 3 liters, usually not more than 4 liters per minute. People sometimes think, well, if a little bit is good, then more must be great. And they will try turning the oxygen up. And as we're pumping in more liters per minute, right, more air, then they're retaining more CO2. And they're going to wind up in a severe hypercapnic state. So, you know, never, rule of thumb, with COPD, any obstructive pulmonary disease, never, ever turn up the oxygen. You want to make sure they understand that. And then, you know, they can have supportive care. In other words, maybe they need help as far as a home health nurse, pulmonary rehab, which sometimes can help. And that's where they can actually go to a rehabilitation facility and get PT or OT to help them learn ways to do their activities of daily living without exhausting themselves. Mechanical ventilation, surgery, and, you know, sometimes even end-of-life planning like hospice, okay? So the next couple slides talk about nursing diagnoses, and then we're going to talk about asthma, and we're almost done. I know, it's been long. So asthma is inflammation of the bronchial mucosa. So inside the bronchus, this is the main bronchus, the bifurcation of the bronchus, one to the left, one to the right, and inside it's lined with smooth muscle tissue. What happens is they spasm, E. And when they do that, air gets trapped. And when air gets trapped, that's when you hear that telltale, that wheeze, that musical sound. They cannot get the air out. Now, it can be reversible because asthma can affect, say, babies. Premature babies, babies that are born prior to the 37th week of gestation, are at high risk for having childhood asthma, but they can outgrow it, okay? So it can be reversible. But what we do see with asthma is that if it is active for quite some time with chronic inflammation and spasming, then it can cause a remodeling of their airway. In other words, the airway doesn't look the way it's supposed to. It changes shape, okay? And that's not good because that makes them retain CO2. So etiology, heredity, you know, allergies can trigger an asthma attack. So if you are allergic to, say, pollen, that kind of thing, that can trigger it. Pollution in the air, cigarette smoke, lots of things can trigger an asthma attack. And signs and symptoms, the classic signs and symptoms are that shortness of breath, I can't say that enough, the dyspnea, and that really significant wheezing, okay? Use of accessory muscles, just like with COPD. And for some reason, with kids especially, worse at night than it is during the day. Okay? And then complications, the only one that I want to talk about is status asthmaticus, which means that you have a patient that has severe, sustained asthma. So in other words, it doesn't come and go. It comes and stays. It's packed its bags and it's staying for a while. And when that inflammation in there is sustained, the hypoxemia, in other words, it's a dangerously low level of oxygen, gets worse and worse. And this is a life-threatening disorder. Okay. So, again, diagnostic tests, H&P, spirometry, ABGs. If the asthma is triggered by allergies, we can do allergy testing, skin testing, blood testing. What are the allergies? Keep them away from those allergic pathogens that are triggers for the attacks. And then, of course, therapeutic interventions. Like I just said, keep them away from the things that trigger. And with therapeutic interventions, as far as meds, there are short-acting beta agonists and long-acting beta agonists. So in other words, a short-acting one, the one you got to know, albuterol. That is the MDI rescue inhaler. Acts quick. Take a nice deep puff of it in. It is going to bronchodilate now. Then you have long-acting, like tiotropium. And that's the one that I told you guys about, but I'm going to say it again. With tiotropium, Spiriva, there is a capsule that is inserted into a little MDI that has 2 pins, and the pins pop the capsule when the patient pushes the button on the MDI. So as soon as the capsule is popped with the pin, this powdered medication comes out and they inhale the powder. Please don't let them swallow the capsule. And that's an NCLEX question. Promise. And then leukotriene inhibitors like theophylline, and you need to know Theo, and then montelukast, which is Singulair. With theophylline, just know that it is given typically IV for an acute exacerbation of asthma, and a therapeutic theophylline level, just so you know, 10 to 20. 10 to 20. Theophylline level, 10 to 20. Know that. Theophylline level, 10 to 20. Did I say theophylline level 10 to 20? Don't forget it. I'm going to ask you about it. And then montelukast, which is Singulair, given at bedtime. Given at bedtime. Given at bedtime. No, I don't have dementia. I'm repeating it on purpose. Given at bedtime. And then we have corticosteroids. Corticosteroids decrease inflammation. So I can give a patient an inhaled corticosteroid like fluticasone. I can give it to them IV, like prednisolone, Solu-Medrol, or I can give it to them by mouth, which is like a Medrol dose pack, which is, prednisolone. And the thing is long-term use of steroids carry with it a lot of side effects, like immunosuppression and something called Cushing's syndrome. So, and we're going to get to Cushing's when we get into endocrine, but long-term use, and that would be more than 3 months of steady use of corticosteroids, carries with it some side effects. So again, what's the risk and what's the benefit? For some patients with chronic asthma-related COPD, they will be on a low dose of prednisone every day and forever, because that's the only thing that can keep them stable. Okay? So, and that's it for asthma. Now, cystic fibrosis, this I'm going to make short and sweet. This is hereditary. End of story. And it's a problem with the exocrine glands. They get these really thick secretions. And there's a GI involvement where enzymes from the pancreas that allow their body to break down fat that they eat, those enzymes are blocked. Okay? And this is completely hereditary. So the child would be born with it. And signs and symptoms are this thick, tenacious sputum, frequent respiratory infections. They're going to have the finger clubbing. They're going to have malabsorption syndrome. So in other words, they can't take in fats because of this problem with the pancreas and the exocrine gland function. They're going to have stool that smells awful and kind of floats on the top of the toilet, which is called steatorrhea. In other words, anything that's fatty that they've eaten goes right through them. It doesn't get absorbed. And usually they will wind up, they don't have a very good prognosis, let's put it that way, or a long lifespan. But there is one thing, actually 2 things that I want you to know about this. There's something called kiss your baby. Kiss your baby. Because babies with cystic fibrosis have sweat that's so salty, it's just like you've licked the salt shaker. So they tell you, kiss your baby. When you kiss their skin, it tastes salty. And that is a telltale sign. Babies that do have cystic fibrosis have salt levels, sodium chloride levels that are 4 to 5 times normal. And that is a telltale sign. For therapeutic interventions, keep them hydrated to liquefy the secretions, inhaled mucolytics to help break up the mucus, expectorants, chest physiotherapy, right? And make sure you remember with chest physiotherapy, boom, 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 pound on the lung a little bit, have them move, mobilize the secretions, cough them out, do it again, okay? And then the other important thing, and I'm going to put stars next to this one too, is because of the GI involvement with this disorder, they will be on a pancreatic enzyme replacement. Pancrease or pancreolipase, okay? It is in a capsule, and this is the only time that you will hear me tell you that it is okay. Not only is it okay, but you have to break open the capsule of pancrease and sprinkle it over their meal, okay? Break open the capsule, sprinkle it on their meal, right? That's the only time, because capsules are not meant to be broken. That's why the medicine's in a capsule, except for this. Because what we're doing, we're replacing the pancreatic enzymes that they are short, right? They don't have them, so we're giving it to them. We sprinkle it on the food so that they're able to absorb whatever fat lipids are in that food, okay? That's it for that. And then we've got the good old pulmonary embolism, which is a blood clot that goes into the pulmonary artery and clogs it up, and it can be fatal, okay? They call it a ventilation perfusion mismatch. In other words, air is coming in and out of the lungs, but the blood flow to and from the lungs, from the heart and away from the heart, isn't working. That's the ventilation perfusion mismatch. The ventilation's working, the perfusion is not. So there's an impaired gas exchange, and basically the lung shuts down. So we know a myocardial infarction is a heart attack. Well, they have a lung attack, a lung infarction. There's a nice picture on the next slide, slide 74, that shows you kind of where the pulmonary embolism can land. So you see if it lands in that pulmonary artery and it's blocking blood flow, that lung is just going to shut down. So etiology of this, the most common reason is a DVT, a deep vein thrombosis postoperatively. It can also come from a fat emboli. When people fracture bones or have any kind of orthopedic surgery. And back with musculoskeletal, I talked a little bit about a fat embolus. So that can occur where it breaks off from the bone, travels through the bloodstream just the same way a blood clot would, and it gets lodged into that pulmonary artery. And believe it or not, during labor and delivery, there can be something called an amniotic fluid embolus. Don't worry about that now, but that'll help you next term in term 4 when you get to maternity, okay? So what do? Prevent it. Prevent it. After surgery, early ambulation, right? If they do have a DVT, we'll try to prevent it, but if they do get one, treat it immediately. Patients should be on an anticoagulant, right? Signs and symptoms are, I'm telling you, a sudden onset, like the patient is fine one moment, and then the next moment you have this. Okay? Dyspnea, tachypnea, tachycardia, profound anxiety, bloody sputum. If we don't do something now, they're going to die. Okay? Diagnostic tests, there's something called a D-dimer. I'm not going to get into great detail about a D-dimer. We don't use them a whole lot anymore, but the VQ scan, the lung scan, ventilation perfusion scan, is probably the most frequently used to diagnose a pulmonary embolism. And if it's a blood clot, well, we can give them a thrombolytic, clot buster, anticoagulants, oxygen, surgery, which is an embolectomy. It's very rare. It's used for something called a saddle embolism, where it's a double embolism on both sides of the lungs. Okay, very rare, but it happens. And for some people that have recurrent emboli, we can put in what's called a Greenfield filter. Okay, So it can be jugular or femoral. Femoral is the most common one for people that have recurrent DVTs. And it's a surgically implanted filter that will protect any blood clot from the lower extremity from moving up and getting into their lung, right? So we're preventing it, but it's a more invasive type of prevention. Then you've got some, nursing diagnoses for respiratory failure, respiratory disease. And then just one more quick thing, and then I'm done. When we talk about thoracic surgery, you must know the terms. So when we talk about a pneumonectomy, we're removing a lung. It's not a lungectomy, right? Pneumonectomy, removal of a lung. A lobectomy is removal of one of the lobes of the lung. A resection, also known as a wedge resection, right, is where we go in and whatever lobe maybe has cancer or a tumor, we can actually not remove the whole lobe, but resect it to just remove maybe the cancer. We now have all kinds of robotic surgeries, the Da Vinci, which are video-assisted thoracoscopic surgical procedures. So I'm not going to get into great detail about them. And then, you might need a new lung transplant. All right, well, I hope you enjoyed that. That was a lot of information. I know. But I eliminated probably 30 slides, if you can believe it, from this. So that is the meat and potatoes of it. And that's all I have for now. So stay with me. I'm telling you, you want that license. I'm going to get you there. ATI, peace. I'm out. Bye, guys. Till next time.